McGraw-Hill Professional presents The Innovator's Prescription, a disruptive solution for healthcare. Written by Clayton M. Christensen, Jerome H. Grossman, M.D., and Jason Huang, M.D. Narrated by Scott R. Pollak. Introduction. In 1970, the cost of health care in the United States accounted for approximately 7% of gross domestic product. In 2007, it accounted for 16% of America's GDP. Normally, we view it as good news when an industry gains share of wallet in such a manner because it indicates that enterprises are making products or services that customers value and seek to purchase. At one level, therefore, we ought to be treating the fact that Americans are spending more of their income on health care as good news. They value good health. They're certainly better off spending it on health than many other diversions. But at another level, this news is terrifying. We note just 4 frightening factors. 1. The growth in health care spending in the United States regularly outpaces the growth of the overall economy. Over the last 35 years, while the nation's spending on all goods and services has risen at an average annual rate of 7.2%, the amount spent on health care has grown at a rate of 9.8%. As a consequence, an increasing proportion of Americans simply cannot afford adequate care. Many efforts to contain overall cost have the effect of making care inaccessible on a convenient and timely basis for all of us, even for those who can pay for it. 2. Second, if federal government spending remains a relatively constant percentage of GDP, the rising cost of Medicare within that budget will crowd out all other spending except defense within 20 years. 3. The third factor that engenders fear is that the burden of covering the cost of health care for employees, retirees, and their families is forcing some of America's most economically important companies to become uncompetitive in world markets. Health care costs add over $1,500 to the cost of every car our automakers sell, for example. 4. The fourth frightening factor, about which few people are aware, is that if governments were forced to report on their financial statements the liabilities they face resulting from contractual commitments to provide health care for retired employees, nearly every city and town in the United States would be bankrupt. There is no way for them to pay for what they are obligated to pay, except by denying funding for schools, roads, and public safety, or by raising taxes to extreme levels. Health care is a terminal illness for America's governments and businesses. We are in big trouble. The rest of the world isn't far behind. Nationalized health systems, such as those in Canada and the United Kingdom, generally seem good at making everyday care conveniently accessible to most people. Some appear to maintain a better balance between general and specialty care than the United States. However, budget limitations continue to result in long lines for specialty services and technologically advanced care. The straits in which Canada's public, paid-for system finds itself, for example, prompted Chief Justice Beverly McLachlin of the Supreme Court of Canada to opine in 2005 that access to a waiting list is not access to health care. Even in the UK, where the National Health Service has made impressive strides in cutting wait times and upgrading facilities, the dramatically increased cost has not been offset by improved productivity. We look to each other for answers that nobody seems to have. Even while many Americans have begun to look to a single-payer, government-controlled health system as an answer to the crisis in the United States, some governments with nationalized systems have recently introduced competing private insurance plans that offer their citizens a wider array of choices. And in developing countries, the notion of somehow replicating the systems of the developed world is simply unthinkable. Their only option seems to be adequate care for the rich and little for everyone else. The U.S. system's cost is fueled by a runaway reactor called fee-for-service reimbursement. It has taught us that the economist Jean-Baptiste Say was right, at least for this industry. When caregivers make more money by providing more care, supply creates its own demand. By some estimates, a staggering 50% of health care consumed seems to be driven by physician and hospital supply, not patient need or demand. Those fighting for reform have few weapons for systemic change. Most can only work on improving the cost and efficacy of their piece of the system. There are very few system architects among these forces that have the scope and power of a commanding general to reconfigure the elements of the system. Perhaps most discouraging of all, however, is that there is no credible map of the terrain ahead that reformers agree upon and trust. They are armed with data about the past, and they have become accustomed to reaching consensus for action when the data are conclusive. But because there are no data about the future, there is no map available to convincingly show these reformers which of the pathways ahead of them lead to a dead end and which constitute a promising road to reform. And few have a sense for the interconnectedness of these pathways. As the prophet of Proverbs said, "Where there is no vision, the people perish." So why this book? There is little dispute that we need a system that is competitive, responsive, and consumer-driven, with clear metrics of value per dollar being spent. Our hope is that the Innovator's prescription can provide a roadmap for those seeking innovation and reform, an accurate description of the terrain ahead, about which data are not yet available. Much of today's political dialogue on health care reform centers on how to pay for the cost of health care in the future. This book offers the other half of the equation: how to innovate to reduce costs and improve the quality and accessibility of care. We don't simply ask how we can afford health care. We show how to make it affordable, less costly, and of better quality. Almost every day somewhere in the United States, a group of healthcare reformers convenes a conference. We've attended many of these. Nearly without exception, the participants talk past each other. This one focuses on the uninsured poor, that one on prescription coverage for the elderly, another on overuse of expensive diagnostics technology, and still someone else on the cost of end-of-life care. Someone decries the perversions of fee-for-service reimbursement, while someone else bewails the failings of capitation. They talk past one another because they don't share a common language and a common understanding of the root causes of these problems. Unable to agree on the problem, and without a language for understanding one another, they find it impossible to articulate and agree upon promising solutions. We hope this book helps these reformers understand the root causes of America's health care malaise so they can frame solutions that staunch the problems at their source. And we hope to give them a common language so that we understand one another and can work cooperatively. The approach we take in The Innovator's Prescription is unique. We have not studied health care to derive solutions for health care. Rather, our aim is to examine this industry through the lenses of general models of managing innovation that have emerged from 20 years of studying these problems at Harvard Business School and the Kennedy School of Government at Harvard. These models have been insightfully applied to industries as diverse as national defense, automobiles, financial services, telecommunications, computer hardware and software, public education, and steel. They have been used to help entire national economies remain competitive and prosperous. They have helped companies innovate in industries that are heavily regulated, as well as in those that are not. We use these models in this book first to explain the root causes for why health care has become progressively expensive and inaccessible. With the causes of these problems defined, we then draw upon these models to show how to solve them. What follows is a summary of our primary assertions, in order to give our readers a roadmap of sorts for this book. The subsequent chapters then offer deeper analysis of the problems and solutions from as many perspectives as possible. Affordability and convenient accessibility. The problems facing the healthcare industry actually aren't unique. The products and services offered in nearly every industry at their outset are so complicated and expensive that only people with a lot of money can afford them, and only people with a lot of expertise can provide or use them. Only the wealthy had access to telephones, photography, air travel, and automobiles in the first decades of those industries. Only the rich could own diversified portfolios of stocks and bonds, and paid handsome fees to professionals who had the expertise to buy and sell those securities. Quality higher education was limited to the wealthy who could pay for it and the elite professors who could provide it. And more recently, mainframe computers were so expensive and complicated that only the largest corporations and universities could own them, and only highly trained experts could operate them. We will come back to this last example below. It's the same with health care. Today, it's very expensive to receive care from highly trained professionals. Without the largesse of well-heeled employers and governments that are willing to pay for much of it, most health care would be inaccessible to most of us. At some point, however, these industries were transformed, making their products and services so much more affordable and accessible that a much larger population of people could purchase them, and people with less training could competently provide them and use them. We have termed this agent of transformation disruptive innovation. It consists of three elements. 1. Technological enabler. Typically, sophisticated technology whose purpose is to simplify, it routinizes the solution to problems that previously required unstructured processes of intuitive experimentation to resolve. 2. Business model innovation. Can profitably deliver these simplified solutions to customers in ways that make them affordable and conveniently accessible. 3. Value network. A commercial infrastructure whose constituent companies have consistently disruptive, mutually reinforcing economic models. In the middle of these three enablers are a host of regulatory reforms and new industry standards that facilitate or lubricate interactions among the participants in the new disruptive industry. To illustrate how these enablers of disruptive innovation can combine to transform a high-cost, expertise-intensive product into one that is much more affordable and simple, let's briefly review how it transformed digital computing. The computer revolution. Until the 1970s, there were only a few thousand engineers in the world who possessed the expertise required to design mainframe computers, and it took deep expertise to operate them. The business model required to make and market these machines required gross profit margins of 60% just to cover the inherent overhead. The personal computer disrupted this industry by making computing so affordable and accessible that hundreds of millions of people could own and use computers. The technological enabler of this disruption was the microprocessor, which so simplified the problems of computer design and assembly that Steve Wozniak and Steve Jobs could slap together an Apple computer in a garage, and Michael Dell could build them in his dorm room. However, by itself, the microprocessor was not sufficient. IBM and Digital Equipment Corporation, DEC, both had this technological enabler inside their companies, for example. DEC eschewed business model innovation and tried instead to commercialize the personal computer from within its mini-computer business model, a model that simply could not make money if computers were priced below $50,000. IBM, in contrast, set up an innovative business model in Florida, far from its mainframe and mini-computer business units in New York and Minnesota. In its PC business model, IBM could make money with low margins, low overhead costs, and high unit volumes. By coupling the technological and business model enablers, IBM transformed the computing industry and much of the world with it, while DEC was swept away. And it wasn't just the makers of expensive computers that were swept away. The systems of component and software suppliers and the sales and service channels that had sustained the mainframe and mini-computer industries were all disrupted by a new supporting cast of companies whose economics, technologies, and competitive rhythms match those of the personal computer makers. An entire new value network displaced the old network. 1. Disruptive technological enablers in healthcare. Our bodies have a limited vocabulary to draw upon when they need to express that something is wrong. The vocabulary is comprised of physical symptoms, and there aren't nearly enough symptoms to go around for all of the diseases that exist, so diseases essentially have to share symptoms. When a disease is only diagnosed by physical symptoms, therefore, a rules-based therapy for that diagnosis is typically impossible, because the symptom is typically just an umbrella manifestation of any one of a number of distinctly different disorders. The technological enablers of disruption in healthcare are those that provide the ability to precisely diagnose by the cause of a patient's condition, rather than by physical symptom. These technologies include molecular diagnostics, diagnostic imaging technology, and ubiquitous telecommunication. When precise diagnosis isn't possible, then treatment must be provided through what we call intuitive medicine, where highly trained and expensive professionals solve medical problems through intuitive experimentation and pattern recognition. As these patterns become clearer, care evolves into the realm of evidence-based medicine or empirical medicine, where data are amassed to show that certain ways of treating patients are, on average, better than others. Only when diseases are diagnosed precisely, however, can therapy that is predictably effective for each patient be developed and standardized. We term this domain precision medicine. As we'll see in Chapter 2, disruption-enabling diagnostic technologies long ago shifted the care of most infectious diseases from intuitive medicine, when diseases were given labels such as consumption, to the realm of precision medicine, where they can be defined as precisely as different types of infection, different categories of lung disease, and so on. To the extent that we know what type of bacterium, virus, or parasite causes one of these diseases, and when we know the mechanism by which the infection propagates, predictably effective therapies can be developed, therapies that address the cause, not just the symptom. As a result, nurses can now provide care for many infectious diseases, and patients with these diseases rarely require hospitalization. Diagnostics technologies are enabling similar transformations, disease by disease, for families of much more complicated conditions that, historically, have been lumped into categories we have called cancer, hypertension, type 2 diabetes, asthma, and so on. 2. Disruptive business model innovations. In healthcare, however, many technological enablers have not yet been translated into lower cost, higher quality, more accessible services. The reason? Because of the factors we will explore in this book, the delivery of care has been frozen in two business models, the general hospital and the physician's practice, both of which were designed a century ago when almost all care was in the realm of intuitive medicine. The lack of business model innovation in the healthcare industry, in many cases because regulators have not permitted it, is the reason healthcare is unaffordable. Chapters 1, 3, 4, and 5 describe what these business model innovations might look like and suggest pathways by which entrepreneurs and regulators can accelerate the processes of disruption that have already begun in every branch of the healthcare industry. Generically, there are three types of business models: solution shops, value-adding process (VAP) businesses, and facilitated networks. The two dominant provider institutions in healthcare, general hospitals and physicians' practices, emerged originally as solution shops. But over time, they have mixed in value-adding process and facilitated network activities as well. This has resulted in complex, confused institutions in which much of the cost is spent in overhead activities rather than in direct patient care. For each to function properly, these business models must be separated in as pure a way as possible. Solution shops. These shops are businesses that are structured to diagnose and solve unstructured problems. Consulting firms, advertising agencies, research and development organizations, and certain law firms fall into this category. Solution shops deliver value primarily through the people they employ, experts who draw upon their intuition and analytical and problem-solving skills to diagnose the cause of complicated problems. After diagnosis, these experts recommend solutions. Because diagnosing the cause of complex problems and devising workable solutions has such high subsequent leverage, customers typically are willing to pay very high prices for the services of the professionals in solution shops. The diagnostic work performed in general hospitals and in some specialist physicians' practices are solution shops of sorts. Highly trained experts amass information from imaging and other monitoring equipment, analysis of blood and tissue samples, and personal physical examinations. They'll then intuitively develop hypotheses of the causes of patients' symptoms. When the diagnosis is only an uncertain hypothesis, these experts typically test the hypothesis by applying the best available therapy. If the patient responds, it verifies the hypothesis. If not, the experts iterate through cycles of hypothesis testing in an attempt to diagnose and resolve the problem. Payment almost always is made to solution shop businesses in the form of fee for service. We've observed that consulting firms such as Bain & Company occasionally agreed to be paid in part based upon the results of the diagnosis and recommendations their teams have made. But that rarely sticks, because the outcome depends on many factors beyond the correctness of the diagnosis and recommendations. So guarantees about total costs and ultimate outcomes can rarely be made. Value-adding process businesses. Organizations with value-adding process business models take in incomplete or broken things and then transform them into more complete outputs of higher value. Retailing, restaurants, automobile manufacturing, petroleum refining, and the work of many educational institutions are examples of VAP businesses. Some VAP organizations are highly efficient and consistent, while others are less so. Many medical procedures that occur after a definitive diagnosis has been made are value-adding process activities. These range from a nurse prescribing medication to cure strep throat after it was diagnosed by a rules-based diagnostic test, to hernia repair, angioplasty, and laser eye surgery. VAP procedures are possible only after a definitive diagnosis has been made first, quite often in a solution shop. When VAP procedures such as these are organizationally separated from those of solution shops, overhead costs drop dramatically. Focused VAP clinics typically can deliver comparable care at prices that are half of those incurred in hospitals and physicians' practices in which VAP and solution shop business models are conflated. Institutions such as the Minute Clinic, Shouldice Hospital, eye surgery centers, and certain focused heart health and orthopedic hospitals are examples of value-adding process businesses. VAP businesses typically charge their customers for the output of their processes, whereas solution shops must bill for the cost of their inputs. Most of them even guarantee the result. They can do this because the ability to deliver the outcome is embedded in repeatable and controllable processes and the equipment used in those processes. Hence, restaurants can print prices on their menus, and universities can sell credit hours at guaranteed prices. Manufacturers of most products publish their prices and guarantee the result for the period of warranty. Since they operate in the realms of empirical and precision medicine, VAP businesses in the healthcare industry can do the same thing. Minute Clinic posts the prices of every procedure it offers. Eye surgery centers advertise their prices. And Geisinger's heart hospitals can specify in advance not just the price of an angioplasty procedure, but can guarantee the result. In a new and remarkable agreement with several European governments, Johnson & Johnson has guaranteed that its new drug, Velcade, will effectively treat a specific form of multiple myeloma that can be diagnosed with a particular biomarker. Or it will refund to the health ministry the cost of the full course of therapy. J&J can do this because the treatment is undertaken after a definitive diagnosis has been made. Many who have written about the problems of healthcare decry the fact that the value of healthcare services being offered by hospitals and doctors is not being measured. To them, we would explain that the reason isn't that these providers don't want to provide measurable value, they simply can't, because under the same roof they have conflated fundamentally different business models whose metrics of output, value, and payment are incompatible with one another. Facilitated networks. These are enterprises in which people exchange things with one another. Mutual insurance companies are facilitators of networks. Customers deposit their premiums into the pool, and they take claims out of it. Participants in telecommunications networks send and receive calls and data among themselves. eBay and Craigslist are network businesses. In this type of business, the companies that make money tend to be those that facilitate the effective operation of the network. They typically make money through membership or user fees. Networks can also be an effective business model for the care of many chronic illnesses that rely heavily on modifications in patient behavior for successful treatment. Until recently, however, there have been few facilitated network businesses to address this growing portion of the world's healthcare burden. Organizations like D-Life, which facilitates the networking of people with diabetes and their families, are evolving toward models that can deal with the particular challenges in treating these chronic illnesses. Waterfront Media and WebMD are building facilitated networks for patients with chronic diseases. Harnessing a vast array of patient data, they're building the capability for patients to find someone like me. This will allow patients to compare progress in treating their disease with directly comparable patients, and ultimately enable those patients to communicate with and learn from each other. The physician's practice business model is a horrible mismatch with the nature of care for many chronic diseases. Facilitated network business models in healthcare can be structured to make money by keeping people well, whereas solution shop and VAP business models make money when people are sick. So what's the answer? The healthcare system has trapped many disruption-enabling technologies in high-cost institutions that have conflated two and often three business models under the same roof. The situation screams for business model innovation. The first wave of innovation must separate different business models into separate institutions whose resources, processes, and profit models are matched to the nature and degree of precision by which the disease is understood. Solution shops need to become focused so they can deliver and price the services of intuitive medicine accurately. Focused value-adding process hospitals need to absorb those procedures that general hospitals have historically performed after definitive diagnosis. And facilitated networks need to be cultivated to manage the care of many behavior-dependent chronic diseases. Solution shops and VAP hospitals can be created as hospitals within hospitals if done correctly. The reason why this basic segregation of business models must occur from the outset of disruption is that it will enable accurate measurements of value, costs, pricing, and profit for each type of business. A second wave of disruptive business models can then emerge within each of these three types. Powerful online tools can walk physicians through the process of interpreting symptoms and test results to formulate hypotheses. Then help them define the additional data they need to converge upon definitive diagnosis. This will enable lower-cost primary care physicians to access the expertise of, and thereby disrupt, specialist practitioners of intuitive medicine. Likewise, ambulatory clinics will disrupt inpatient VAP hospitals. Retail providers like Minute Clinic, which employ nurse practitioners rather than physicians, need to disrupt physicians' practices. Hospitals and physicians' practices have long defended themselves under the banner, "for the good of the patient." Yet, for the good of the patient, do we really need to leave all care in the realm of intuitive medicine? Much technology has moved past this point, and healthcare business models need to catch up. Two landmark reports from the Institute of Medicine, Crossing the Quality Chasm and To Err is Human, shattered the myth that ever-escalating cost was the price Americans must pay to have the high-quality care that only full-service hospitals, staffed by the best doctors, can provide. Introduction continued. 3. A disruptive value network. Systemic reform versus piecemeal insertion. The third enabler of disruption is the coalescence of an independent.
Sample complete. Ready to continue?